we are getting about 2,500 every day.
Wow.
Both of us can see each other.
Yes, tell me, Neeraj, when we have to.
Yes. We are live now. Over to Dr. Dhiren Ganjwala, President of Pediatric Orthopaedic Society of India.
Good evening, friends. Welcome to the Pediatric Orthopaedic Society webinar. This is our 26th webinar. The topic for today's webinar is management of hip and knee problems in arthrogryposis. And we are really fortunate to have the expert on the subject, Dr. Harold van Bosse from Philadelphia Shriners Hospital with us. In addition, we have four other experts from India, the senior-most or one of the senior-most pediatric orthopedic surgeon of India, Professor Sriram. Then we have Dr. Hitesh Shah from Manipal, Dr. Bobby John from CMC Ludhiana, and Vijay Sriram from Chennai. They will be like showing their cases, and we will have a case discussion after the lecture. So now I request Professor K. Sriram to introduce our faculty. Over to you, Professor.
Thank you, Dr. Dhiren. It's a great pleasure that I introduce the speaker of the day, Dr. Harold van Bosse from USA. He completed his orthopedic residency in 1994, followed by a year of fellowship at the Hospital for Sick Children, Toronto. He then moved to New York City, where he worked till 2008. At that point of time, he changed his location to the Shriners Hospital in Philadelphia. And he took special interest in arthrogryposis multiplex congenita and opened a separate center for this disease. And since then, he has been involved in the correction of deformities of the limbs and making functional adaptive devices for those children. In addition, he also is interested in Prader-Willi syndrome from way back in 1998 when he had the first case of Prader-Willi with scoliosis. So these two subjects, AMC and Prader-Willi, occupies nearly 90% of his time. That is because he gets references from both the Americas, Europe, Asia. But he is interested in doing all aspects of pediatric orthopedics. But his hobbies are music. He is very fond of pop music, and he consistently plays the music in the OR. And he is also very much interested in voluntary work in parts of India, Peru, Colombia, and Haiti. He's well supported by his wife, Mrs. What is her name? His wife, Anna. I'm sorry, I didn't get the name, Anna. And now may I request Dr. Harold Bosse to deliver his talk on arthrogryposis with involvement of hip and knee. Thank you.
Thank you very much, Dr. Sriram. That was a wonderful introduction. I want to thank POSI, and particularly my friend, Dr. Ganjwala, for inviting me to give this talk. So let me see if I can make this work. And all right, do you see my talk there? Is it there?
No, we don't see it. Can you just click on share screen?
Let me try this again. And how about now?
Now, yes.
Is there?
Yes. It's
okay. There. So today we're going to talk about a few different topics in arthrogryposis. We'll start off talking about the hips. So the hips are important for your ability to walk. If you think about it, if you have bad club feet, you can walk. If you have bad knee contractures, you can walk. But if you have hip contractures, you really can't get your feet below you to be able to walk. Now, the hip deformities in arthrogryposis come in two forms. You have the congenitally dislocated hips, and you have the hip contractures. So let's first talk about hip dislocations. About 30% of patients with arthrogryposis will have hip dislocations. These are teratologic dislocations. They happen much earlier in pregnancy than what you see in idiopathic hip dislocations. The hips are stiffer, the dislocations are higher, and there's always been a concern that if you put the hips back in joint, they may become painful or stiff. So the common practice that I was told when I started practice was that if one hip was out, you could try to put it back in, but if both hips were out, you should leave them out. And if you're trying to figure out, there's a number of important people who have mentioned that in their articles, but if you try to figure out where this comes from, who was the first person to say it, it all comes down to this abstract that was published in 1961 from a meeting by a Dr. Hansen. And really all he said was this: when one hip was dislocated, the operation was worthwhile, but not when both hips were affected. And he had absolutely no data to support that. And yet there's been over the years, many good articles that have been out there saying that if we do put the hips back in, that we have a higher rate of independent ambulation. But we're still having a hard time getting this message out that putting the hips back in arthrogrypotics is helpful. Our philosophy has been that if you reduce the hips, you improve walking efficiency. And if you improve the efficiency, you have a better chance of adults continuing to walk. And what we also got to thinking was that it may be more a matter of that the hips already are a little bit stiff to start off with. And when you put them back in joint, you're not making them necessarily stiffer than they were before surgery. I do my procedure through a medial approach, and I go between the neurovascular bundle and the pectineus. And in 2006 or so, I learned this wonderful technique when I was actually traveling through India. And I think it was Dr. Gunjwala who introduced me to it. The idea of using the ligamentum teres to tether the femoral head back inside the acetabulum. So what I do is I'll make a little loop of suture through the acetabulum, coming through the anterior wall and then looping back through. And I'll use an absorbable suture to do that. And I'll take the ligamentum teres and kind of thread it through that loop. And when I reduce the head, I'll use that loop to snare down the ligamentum teres, such as that. So we reviewed our data, and I have to update this so I can get this published, but we had about 40 patients with 58 hips. And we looked at their range of motion, both before surgery, after surgery, and then at a follow-up, as well as their ambulatory ability. So this is what our data look like, but to kind of narrow it down a little bit. The average age of surgery was about 22 months, but we did have a few kids that we operated on over 4 years of age. The average follow-up was almost 4 years. And about 2/3 of the children needed a femoral shortening done at the time of the surgery. If we look at the total arc of motion comparing the hip to itself from pre-op to post-op, we lost about 5 degrees of total arc. And yet when you looked at pre-op to follow-up, it actually stayed about the same or actually improved maybe a little bit. And it was no longer significant at that point. The abduction to adduction range also decreased a little bit from pre-op to post-op, but that was not statistically significant. Internal and to external total arc of motion did decrease by about 20 degrees, and that was significant. Now, what's interesting is if you looked at those patients who had unilateral hip dislocations, and we could compare one hip to the other, the non-dislocated hip, what we found is that preoperatively, the dislocated hip had a little less of a flexion extension arc compared to the non-dislocated hip, and that did not change between pre-op to follow-up. And the same with the abduction and adduction range, that it changed very little. So what we felt was that if we took a look at the individual contractures that you had, so a dislocated hip tends to be flexed, so it has a flexion contracture, it tends to be adducted and externally rotated. And we looked at each one of those individual contractures. We said, well, the 25 patients who had flexion contractures, they started off on average with about a 30-degree contracture that came down to about a 10-degree contracture. If they lacked abduction, that improved by about 10 degrees. And if they lacked internal rotation, that improved by about 13 degrees. So we were able to center the knee better in general. The one point that is still difficult for me to figure out what to do is the patients who lacked hip flexion. So on average, these would only flex about 70 degrees before surgery. And at follow-up, we'd find that they'd only flex about 60 degrees. So that was definitely a problem. And that's about a third of our patients who had that. But if we look at ambulation, we have 26 or 40 patients that were ambulating independently. Those that were non-walkers, that could not even ambulate with a walker, in retrospect, we found had cognitive impairments. And so that's one of the main things now that I look at is whether or not I think a child has the cognitive ability to walk, not the physical ability, but the cognitive ability. Our rate of avascular necrosis was about 50%, but what you'll notice is that most of those were the type 1 over here, about 17% of those, and those actually improved nicely over time, as you see in this picture on the right. We had a fair number of type 3s, and we just have to see how they continue to reshape themselves over time. But at this time, at least, they are not hindering range of motion very much. And then if we look at hip positioning or residual dysplasia, and we use the International Hip Dysplasia Institute classification, we had a few that were grade 3s. And what I had to do for a number of these was pelvic osteotomies and occasionally with various reorientational osteotomies. And what we would find is that would improve our classification, that we'd get many more of these into the class 1 and just have a few that were 2 or 3s. And we had no frank redislocations. So the conclusion was that an open reduction of the arthrogryposis hip for a congenital dislocation does not lead to greater hip stiffness. And I believe it actually improves their overall function. So here's little Emily. We put her hips back in place. And here she is showing off what she's able to do with that. Now, here's a child that had a chronic hip dislocation. I met this child when she was almost skeletally mature and was walking with a very significant Trendelenburg gait. So we decided to do a pelvic support osteotomy. Essentially, you adduct the hip as far as you can go, make a cut right below the acetabulum, and another cut over here at the metaphyseal diaphyseal junction for lengthening. We lengthened her out so that both legs were about the same length. And here she is a few years afterwards. You can see there's been some remodeling that's happened, but this is what she looks like ambulating. So she has a slight Trendelenburg gait, but actually it walks quite nicely. Now, what about hip contractures? Most of the hip contractures in arthrogryposis are multiplanar, but there are some that are just flexion contractures. And for those, I'll do a percutaneous anterior hip release, essentially incising at the combined tendon of the sartorius and the tensor fascial lata. What you find is that if you flex up the contralateral hip and then take the hip you're looking at and adduct it and extend it, you can actually feel this ridge of tissue here. And that's all we're incising. So we go through the sartorius and the tensor fascial lata, coming over to the lateral side of the tensor fascial lata, right above the greater trochanter. Occasionally also going for the rectus femoris, which is right in front, and sometimes even the fascia that's directly over the iliacus that you can palpate, and usually do this through a very small incision. Incision is usually less than 1 centimeter, sometimes a little bit bigger if I'm going to go to that iliacus. But here, for example, is a girl with a 30-degree hip flexion contracture. So make a little stab incision right to the medial side of that conjoined tendon that you feel. And then follow that incision down to just above the greater trochanter there. You do that underneath the skin. So here we are trying to come all the way down to right above the greater trochanter. And you can see that immediately we have a significant improvement on her hip flexion with just that small procedure. The more typical contracture, though, is a multiplanar abduction, flexion, and external rotations, as you see in these 3 children here. So the problem is not only can it cause issues with walking, but also with sitting, because if they're so contracted, they sometimes can only sit on their feet, for example. So we came up with the idea of a reorientational femoral osteotomy, leaving the femoral head where it wants to be inside the acetabulum, but taking the rest of the leg and reorientating it so that the knee is pointing directly forward, and we have the best range of flexion and extension that the hip will allow. So here's an exemplary case. This young lady here This is what she looked like when we first met her. In her range of motion, she had a 65-degree hip flexion contracture. When we tried to adduct her, she would come to 35 degrees short of neutral. When we tried to internally rotate her, she would come to 15 degrees short of neutral. And that's what her x-ray looked like when she was just at rest. So here's a bone model that I made to look as she does. So we can use this for our example. So the first thing we do is we place what we call the pelvis access wire from anterior superior iliac spine to anterior superior iliac spine. So we can see this under fluoroscopy, as you do right here. And this gives us the true positioning of the pelvis. And then we'll place a guide wire into the proximal femur parallel to this guide wire in all planes. So it looks something like that. And typically they have a significant amount of external rotation to their femur. So this wire will actually be going through the, from cortex to cortex. It does not go up the neck as you typically would put your wire. It's kind of an oblique positioning. Then we'll take a cannulated seating chisel and advance that over the wire with the seating chisel perpendicular to the plane of the pelvis, or to the plane of your operating room table, for example. So again, it's not lined up with the femur as you typically would do. It's actually standing straight up and down. So we insert that. And then we'll make two osteotomies. The first osteotomy is parallel to the seating chisel, and the second osteotomy is perpendicular to the shaft. So we're taking out something of a modified wedge of bone. So that's after the first osteotomy. And do our second osteotomy. And it allows us to put these two edges together. We derotate the leg at this point, so the knee is now pointing directly forward, as you see it over here. And I'll just use a regular 90-degree angled blade plate with an offset and put that into place. Now, if they have a severe flexion contracture, there'll be this big bump of bone that we need to take off, or else that will impinge when we try to flex up. So we'll just shave that off as we did here. So for example, we have this young man pre-op, he's got significant knee flexion contractures, but this is what he looks like post-op, and there he's upstanding. I put them in a Petri cast for about 6 weeks, but at 3 weeks, if I see good healing, they're allowed to start standing in their cast. So we wrote a paper on this about 3 years ago, where we had about 119 hips that we looked at with 2 years of follow-up. And what's so exciting to see is how much remodeling we have. So again, the osteotomy is about this level here. So the greater trochanter on both of these is pointing directly posterior, but with remodeling it is now standing straight proximally. And then we looked at our range of motion. We looked at ambulatory status. Again, this is how much data we collected. But if we look at the typical contractures, that's the flexion, abduction, external rotation contractures. Of the 81 patients or 81 hips that had a flexion contracture, the average flexion contracture is 52 degrees pre-op, and it came down to 15 degrees post-op or at follow-up. Those that could not adduct, we improved that nearly 40 degrees. Those that could not internally rotate, about 35 degrees of improvement. And the total arc of motion in the flexion extension axis went from 73 degrees preoperatively to about 85 degrees postoperatively. And I think that's because once they start walking, they're doing some more exercising of their hips, and they're gradually improving their range of motion just through regular activity. Now, just like with the hip dislocations, we have an interesting problem that those hips that did not flex up very well preoperatively, also, we could not get them to flex up as much as we'd like to postoperatively. And that's still an issue that I'm trying to figure out what to do. Now, if we look at ambulatory status, preoperatively, 6 of the patients were ambulatory, but at post-op, about 2/3 of the patients were now ambulatory. Some of them were still using crutches, but that is usually the way that they kind of progress onwards to full independence. So then there's this patient, for example. This is what her hips actually look like. And there she is on the operating table. There's her x-ray down below. And here she is immediately after the operation. So this right here is actually the cut edge of the bone. This is not the greater trochanter. But what's so fascinating is how much remodeling she got over time to where now the greater trochanters are actually proximal. And here she is up and walking. And then we have my friend Daryl here. We fixed his club feet with casting. And then we got his hips fixed. Sorry, there's his hips that are fixed. And then we had to fix his knees with Illusoral fictional fixators. And here he is up and walking. This is early on. I just saw him yesterday in clinic, and he walks very quickly. So now let's talk about knees. So knees come, of course, in flexion contractures and extension contractures. And sometimes the bigger issue is the lack of total arc of motion, either with a flexion contracture or an extension contracture. And the flexion contractures, what you tend to find is that there is fibrosis of the joint. They have lack of creases around their knees. Their legs tend to be thin and atrophic. There can oftentimes be associated popliteal pterygiums with bowstring of the neurovascular bundle behind the knee, and the bones can be quite thin and gracile. So what are different options? Well, we can do serial casting or extension bracing. And this I did early on in my career of treating children with arthrogryposis, and I never had much success with this. So I've abandoned it a while ago. From time to time, I will hear somebody who has had success with it, but in my hands, it just did not work. So typically, a lot of my patients have, undergo posterior knee releases, and then they either use growth guidance techniques or Illusoral external fixators. Occasionally, distal femoral extension osteotomies work, but these have a high recurrence rate in the skeletally immature. So for example, in this child here, this is a patient that was sent to me after somebody had done an extension supracondylar osteotomy at about a year of age. And you'll see that we go from here to here in less than a year and a half, where they've completely remodeled the osteotomy site and have had a complete recurrence of their contracture. But in an older patient, this works quite well. So either it's taking out a wedge, or sometimes if it's small enough for contracture, just making a single cut and bring the leg back over the top. So here's a 13-year-old young man. He had flexion contractures bilaterally at 30 or 40 degrees. The other problem that he had was a very limited arc of motion. So corrected him out and left him with a little bit of a flexion contracture so that we could use his limited arc of motion at least to be able to sit comfortably. And here he is after he's remodeled some. And actually got a little bit more range of motion over time. So now he flexes 40 degrees on the right and 50 degrees on the left, extends far enough that he's able to ambulate with AFOs. Let's talk a little bit about the posterior knee release. The way I like to do my posterior knee release is through medial and lateral incisions. And I center these over the palpable posterior femoral condyle on both sides. So I'll do the lateral side first. Keep an eye on where the peroneal nerve is, but incise the iliotibial band, the gastrocnemius, and the posterior capsule. I used to incise the lateral collateral ligament as well as the medial collateral ligament a little bit. I don't do that anymore. Now, on the medial side, really the same thing. Incise the hamstrings, the medial gastrocnemius, and the capsule. And the whole idea is that when we're all done, we can actually take a finger from side to side all the way across the knee and feel the condyles all the way across. So for the more mild knee flexion contractures, and here I said for less than 40 degrees, and actually I've gradually come to 45 or 50 degrees if I think that there's enough flexibility in the knee altogether. Then I'll use anterior distal femoral hemiphysiodesis. Essentially what we're doing is we're taking Peter Stevens' little hemiphysiodesis plates and putting one anterior medial and one anterior lateral at about 45 degrees to the sagittal plane of the knee, putting them across. So here's a girl who's 5 years old with a 20-degree knee flexion contracture. And you can see that over time, there's a fair amount of splaying out of the screws here. And if we look at her after hardware removal, you notice that there's quite an angulation to the physis here, and we've been able to get our knee straight, or as I tell the families, we have faked a straight knee because we haven't really changed how the tibia is articulating with the femur, but we just rotated how the femoral condyles are. So in collecting data here, we had 91 knees in 57 patients. The average age that we did the surgery was about 7 years of age, and the average time that the plates were in was about 1.5 years. And then we had about 3 years of follow-up after we took the plates out. So the average contracture about 35 degrees, but we went up to about 55 degrees. And then at the time that we took the plates out, the average residual contracture was about 6 degrees. But you'll see that we actually had some patients that had hyperextension and some that corrected very little. The average correction rate was about 2 degrees per month. So if you look at it here, preoperatively, our average contracture was about 35 degrees. At the time of plates out, it was about 8 degrees, so that was significant. If we look at it 3 years later, we had a recurrence of contracture that was also significant. Went from 8 degrees to about 19 degrees. But you notice it went as high as 70 degrees. But the overall correction was still significant. If we look at the total arc of motion, we went from 72 degrees preoperatively to 57 degrees postoperatively. And then at follow-up, it improved by a few degrees, but that was not significant. And the overall loss was still significant from 72 to 61 degrees. So overall, we lose about 11 degrees or so of range of motion when we do this sort of procedure. And this chart here, what I have on the bottom is what the initial contractures were. And here I have the contracture at the time that we took the plates out. And if we called a residual contracture of less than 10 degrees success, then what you'll see is the ones in red, the X's and reds are those that we did not do a posterior knee release, and the ones in black are the ones where we did do a posterior knee release. And essentially, I think that those knees that had less than a 25-degree flexion contracture, they did okay without a posterior knee release. So we can probably do these without releasing the knee. And if we get up to 45 degrees or greater, we get to a point where we're no longer getting as much correction as we want at the end of the case. So I usually, when I'm looking at a knee that has about a 45-degree or greater contracture, I warn the parents that this might not be the right procedure for them. But if we look in terms of what we've been able to do for the patients functionally, we're able to get from 23 patients who are independently ambulating up to 35, and the non-ambulators from 11 to 2. So significant improvement. Now, we did certainly have recurrences, and that's because after we take the plates out, the physis wants to remodel itself. I tried to combat that by having them in a KAFO, that they wear an extension every night, and we do that for several years, if not until they're done growing. But even though, we still get recurrence at about 0.5 degree per month. And we have had 9 patients or about 14 knees that I've done a second set of these plates. And this is usually at about 3 years or so after we've taken out the first set of plates. The average contracture was about 25 degrees, and we got a pretty good correction out of them. But the correction happens at a slower rate. Instead of at 2 degrees per month, it is now at about 1.25 degree per month. So what I came up with then was a different way of trying to put these plates in. The issue with putting them in with the plates anteromedial and anterolateral is they oftentimes will rub against the extensor complex. So I thought I could maybe do something more off to the side, and we came up with what we call the Fascial bridge technique. So I actually have a plate that is anterior on the physis, one medial and one lateral. We put our screws across, and between the screws, we have left the guide wire. So this way, as the screws start to diverge from each other, they can only go so far before the guide wire limits them. And you'll see that we're able to still get that nice obliquity to our physis over time. And actually seems to go a little bit faster, because here we have a boy who had a 45-degree contracture that in 3 months' time, we had him fully corrected. That's better than average for correction, but still it was a nice case to see. Well, what about the more significant contractures? Well, this is where I move to an external fixator for most of the patients. Usually I'll wait till the patient is at least 4 years of age before I apply this, both because I want bigger anatomy to work with, and I want to have a more mature patient that I put this on. So they're not as not as worried when we get around to taking the frame off and starting physical therapy. Now, the nice thing about an external fixator, because it's a gradual correction, we have less neurovascular risk because we're gradually stretching out the neurovascular bundle. We can stretch out scars. So if this patient's already had a posterior knee release, I can stretch out the scars, and I can also stretch out pterygium, as we're seeing here. And it's non-shortening. We're not having to make them shorter to do this. It is technically complex, and the patients and the families sometimes have difficulties with this. But one of the things that I tell parents when they're looking at this and trying to figure out if it's right for them, I always tell them that when I've had a patient who's had bilateral contractures, I will only do one side at a time because it's hard to have both these knees in the external fixator simultaneously. But once we have finished the first side and we're looking to take that frame off, I've never had a parent say to me, oh, let's not do the other side. This was too hard to go through. They're usually pretty enthusiastic about doing the other side because now they see how straight the one knee has gotten. They want to get the other knee straight and get the child up walking. So we'll do a posterior capsule release first. And then I place a access wire across the knee so I know where the knee arc of motion happens. And then we apply our external fixator. So Hollister came up with this idea that the rotational axis of the knee is essentially where the posterior femoral line intersects with a line that goes across the greatest dimension of the femoral condyles on the lateral view. And oftentimes they'll find in the younger children, this is actually, this line here corresponds to where the physis is. So I'll put a wire across that point as I've done here. And I'll use that wire to hang my joints for the frame. I'm just going to skip ahead for a second, just to see. So here are the joints for the frame. So I can hang these joints for the frame on there. And then what we do when we attach the tibial cage, I'll actually put a wire across that's kind of curved like this. So when I tighten this wire, it actually will bring the tibia a little bit anterior in relationship to the femur, so that as we're straightening out the knee, we don't get a posterior subluxation of the tibia. Then we distract the joint out a little bit, about 5 to 10 millimeters, so we don't get impingement as we're getting into our end of correction. And I like putting my motor, my telescopic rod, I like putting it anterior. Some people like putting it posterior from here to there, but I find this makes it difficult for when patients are sitting, that gets in the way of the wheelchair. So I'll have a much more bulky frame with this big thing, this big outrigger out front, but it does make it easier for them to adjust, and they're much happier as their leg is getting straighter. So this young man, 9-year-old boy with Escobar syndrome, this is what the frame looks like. So I had that wire going across that I hung my hinges on over here. Now that wire comes out before the case is done, but I'll hang a hinge, hang the hinges on here, put my femoral frame on that I attach to the femur, and then attach the tibial frame on. Here's that wire that goes across that we tension to bring the tibia forward, and then distract out the knee a little bit. And then here's my motor that as this telescopic rod collapses, it makes the knee extend. So something along lines like this. And I know this is also done a fair amount in India, because on some of my trips to India, some of the people who showed me around showed me an external fixator it's made in India that they'd also use in a similar fashion. So postoperatively, I want to correct them at a comfortable rate. It's usually about a little bit less than a degree a day that we're straightening them out. Once we get to full extension, we want to keep the frame like that for about 2 to 4 weeks. And actually what I'll do during that time is I'll have them cycle where they'll flex the frame a little bit and then extend it over a few days' time. So we're keeping the knee moving a little bit, but getting to full extension each time. And then what we have, we go back to the operating room, take off the frame, put them in a cast for 4 weeks, and then we'll put them in a KAFO that they keep in extension for a period of time, and then just wear it at nighttime after that. So here we had 72 knees and 44 patients. Average age of surgery was about 8 years of age. In the beginning, I did them as young as about 2.5 years of age. I won't do that again. That was just too tough on the patient. Average follow-up time, about 3.5 years. And so we had about 104 days that it took to correct them. So 104 days that they were in the frame. Usually now I just plan it on being about 3 months in the frame altogether. So our average preoperative contraction was about 70 degrees, but you see we went as high as 105 degrees. This 30-degree contracture was somebody who had a subluxated knee. So I had to put the frame on to correct the knee subluxation. And we got them all to just about fully straight. So here we start off with a 68-degree contracture. Now this early follow-up, this is several months after we've taken off the frame to see where we were at. So that early follow-up, they had about a 13-degree contracture, and 3 years after that, it was about a 23-degree contracture. So all these were significant. From here to here was significant. From there to there was a significant worsening. But from pre-op to follow-up was also significant. The total arc of motion, though, this is where it gets difficult because we lost about 24 degrees and we didn't get much of that back again. And that can sometimes be a difficulty. We get the patients up walking, but then we have to do another procedure later on in order to get their knees to bend better so they can sit in cars and such. But here we had preoperatively, we had 29 patients who were not walking. And by the end of our follow-up, only 2 of them were not yet walking. There's a high recurrence rate, and for most of those patients, I would just do anterior distal femoral hemiphysiodesis plates. And on average, this was about 55 months after taking off the Ilizarov frame. So about 4 years after taking off the frame, we did the hemiphysiodesis plates. So here's a little Simon. We corrected out his feet with the Ponseti cast, and then we took care of his hips so that he could sit regularly. And then this is him standing in his KAFOs. So we knew that he would actually do well if we got his knees straight because he could actually walk in his KAFOs, such as that. We put on his fixators. This is him getting angry at me, or maybe just Halloween. And then this is him showing off when we got him to the point that he could walk with short braces. So my favorite thing to tell young parents when they come to me with a child with arthrogryposis is to reassure them that regardless of what people said of, oh, your child will never walk, there's no way to tell when you first see the child after they're born, what they're capable of doing. I want to talk a little bit about extension contractures. These are usually more of a difficulty later on in life, later on in childhood. So not early on, because early on the children with the straight knees actually are able to learn how to walk quicker, but usually someplace between 6 and 12 years of age, they start having problems with sitting. Now, we do have the occasional hyperextended knee or the dislocated knee. And those they'll start off with treating with serial casting or Botox, but oftentimes they'll need some sort of a Jude or something along those lines to get the knee to flex quicker. And then a quick caveat is if you have a child with a hyperextendable knee and you're also doing your Ponseti casting, it's very important to figure out where the front of the knee is. So this patient here was undergoing casting and they thought that this bump here in the front was the patella. Well, that bump was actually the medial side of the medial femoral condyle. And so by them trying to flex the knee, they actually created a severe stretching of the medial femoral collateral ligament, and now the patient had an incompetent knee that had to be surgically fixed. So the little smiley faces here are actually where the front of the knee is because they had such severe external rotation of their hips, and that's something we just have to pay attention to. So that's what we want to do is make sure that we have the knee rotated anterior when we try to flex it. So in order to get the knees to flex, I'll do a Jude quadriceps plasty, and either that will be an entire incision along the side of the thigh here, or sometimes I'll do multiple smaller incisions to get to it. But my overall treatment algorithm is that at infancy, I'll work on the foot deformities with casting. Oftentimes we have to repeat those. We call that serial casting. And then I'll work on the hips, usually between a year and a half, if I'm able to get to it that early. Many times, though, the patients are much older when I first get to meet them. And then I'll address the knees when they're about 4 years of age. So here's this young lady. That's what she looked like when we met her. This is when she's up and standing. And here's the first time that she started walking for us with her KAFOs. So I want to thank everybody for their attention and for inviting me to give this talk. It was a great pleasure to do so.
Yes, Hitesh, can you take over now?
Yeah, thank you very much for the extensive talk regarding the management of the hip and knee. It's a very complex issue. Arthrogryposis is the complex issue for the in pediatric orthopedic because it's not a straightforward problem. It's not a DDH or the hip or knee problem, club foot also. So I have a question from the audience that is regarding that till what age would you do about open reduction for the dislocated hip? Whether the protocol would be different for unilateral and bilateral hip? What is the oldest age?
So the oldest age, I've actually done one child at 5 years of age, and he has done rather well. He was a very flexible child, though, before the procedure, so I felt comfortable with him. In general, I like to do it before 3 years of age, but I do have a few that I've done later than that, and they have done all right.
Okay. The protocol is different for unilateral and bilateral hip?
Not for me. If I have a unilateral hip dislocation, usually the contralateral side will have a contracture. So on the one side, I'll do the open reduction. On the other side, I'll do a reorientational osteotomy, and I still will put them in a hip spica cast afterwards.
Okay.
So do you always go anterior, medial? Sorry, Hitesh, just to butt in.
Yeah.
I have always done them anterior. But I have to qualify that for a second. My training was, as Dr. Hitesh had said, my training was in Toronto, and actually I trained under Dr. Salter, and Dr. Salter did everything through an anterior approach. And so that's how I started doing my arthrogrypotic hips. But then I had a short series or a short group of them that had heterotopic ossification. And that really started to concern me. So I went back and looked at the literature, and Dr. Lynn Staley in Seattle had written about doing open reductions on these hips, and he did his through a medial approach. And so I actually had to teach myself how to do a medial approach, which isn't all that hard to do, but I had never done one in my training. And I've now been doing that for at least the last 15 to 18 years. And feel very comfortable, particularly because you're able to do that ligamentum teres tethering. That really seems to help.
Okay.
But what if you need a pelvic osteotomy?
Well, then you're right. Then I will do an anterior approach.
So is there an age limit where you will do medial?
There hasn't been yet, but your point is very good, that if I'm looking at the socket and saying, boy, that looks like it is deficient, and then I think from the start, I'll need to do a pelvic osteotomy. Then I will do an anterior approach for that.
All right, thanks.
Pardon me. So I try to hold off doing pelvic osteotomies until 4 years of age. That's just my preference. So usually if I'm doing these hips at a younger age, then I decide I'm just going to do the open reduction of the hip and then continue to watch them and then do the pelvic osteotomy later. But I do have colleagues who will look to combine everything at the same time, even as young as 2 years of age.
Yeah, thanks.
Is that the AVN rate is different from the anterior approach and medial approach, or it's the same?
I'm sorry, which approach was that?
The avascular necrosis, the frequency of avascular necrosis through the medial approach and anterior approach. What is your experience?
I can't tell you. So I just lost you there. Okay. I can't tell you. I didn't do enough of the anterior approaches to be able to compare the two, or I've never meant to do that. Maybe I should go back and take a look at that.
Okay. Another question is there. What is the role of the cordyceps tenotomy for the treatment of the dislocated hip or congenital extension contracture, cordyceps contracture?
That's a good question. typically when I do the open reduction on those children with the knee extension contractures, I'll release the rectus femoris, but I won't do much else to the quadriceps. So the rectus femoris is, of course, the only knee extensor that crosses the hip. Now, I don't know how much that does, or I don't think that does much at all for the knee itself. And so that knee will need to be addressed in the future.
Okay. Another question, that is there any measure to assess the walking potential of the newborn? And that is the real question for all of the surgeons with the arthrogryposis.
That's a really good question. And that's a tough one. For the most part, most of the orthogrypotic kids that we see are those children with amyoplasia, and most of those children are pretty smart. So then it's more a matter of, occasionally you just have a child who has a total locomotion of 20 degrees at the hips and 20 degrees at the knees and the terrible contractures. And that child you're probably never going to win with. But if they have more suitable range of motion, then I think it's always worth putting those hips back in. But when you have those children that just, they are not looking very interactive, oftentimes they seem to have a short neck because they weren't moving their neck very much. Those are the ones that probably the source of their arthrogryposis is more of a brain malformation. Either it's an absent corpus callosum, or it can be perisylvian polymicrogyria. Those children, I am now much more hesitant to address. And what I'll tell the parents when I first meet the child, a year of age, I'll say, you know what? I can probably put this hip in until the child's maybe 4. Let's follow them together. Let's see what the child does. If the child really starts to show us some potential for wanting to get around, to interact with their environment, then we can put the hip back in. But if the child doesn't really seem to do a whole lot, then we won't. So I never say I'm not going to do it. I say, let's let the child tell us. And I think that's palatable for the parents. And I've had a few times where, 3 years of age, suddenly the child looks a lot more interactive and they're trying to get around, they're trying to crawl. Okay, then that's maybe somebody who's going to do well.
Yes, it's a great answer. This is my personal view also. It's not been studied, but whenever we'll have the CHST3 mutation, where we're having very different, where there is a short neck, there is a skeletal dysplasia, where the spondyloepiphyseal dysplasia, dislocation type. They don't behave like the typical amyoplasia or AMCC. So they do behave differently. They, as you pointed out, they will have the cognitive function impairment. They'll have the brain problem. So they do not do very well with the treatment, but it is very difficult to predict.
Yeah.
One more question, that how do you advise a mother with the antenatal diagnosis with the arthrogryposis?
Oh, that's a very tough one. And when we get together with different people who do arthrogryposis, we struggle with this a lot. One of my mentors in arthrogryposis is Judy Hall, who is a geneticist who has written the most articles on arthrogryposis out there. And what she always likes to talk about is doing intrauterine physical therapy. So that once you have a diagnosis of arthrogryposis and you're in the middle of the 2nd trimester of pregnancy or in the 3rd trimester, she feels we need to get these babies moving as much as possible. So she talks about having the mother exercise, or even several times an hour, having the mother take several deep breaths to get the child to wake up and move around some. And have the mother drink a fair amount of coffee, so that stimulates the baby to move. So she feels the more movement the baby gets intrauterally, the better that the joints are going to do. Now, from my standpoint, I think the big thing to worry about is what the brain looks like. So you probably have some of the same issues that parents will say, well, we've been advised we should get a termination of pregnancy. What do you think we should do? And my feeling is that they can always do the chromosomal work. They can get an amniocentesis or a chorionic villus sampling, but getting an MRI and looking at what the head looks like and what the brain looks like is probably one of the more helpful things to do to understand if that baby is going to do well and help the parents make their decision.
Okay, thanks. another question, in bilateral dislocated hip, how do you judge pre-operative whether they will become stiff post-operative? Can you predict?
So from looking at our series of patients, what we can predict is that the range of motion at follow-up, not just at post-operative, but many years after the procedure, is going to be very similar to what the range of motion was before surgery. So with that in mind, you can feel comfortable if you have a reasonably good range of motion. If the flexion extension arc is 80 degrees or so, you can feel reasonably good that that patient's going to have a suitable range of motion, both for walking and for sitting, for example.
Okay. One more question. What is the role of upper limb function for deciding factor for the walking in the arthrogryposis?
It should have a lot of role, but to be honest, I have a couple of hand surgeons I work with very closely, Dr. Kozin being one of them, but we don't really decide on each other's operations. So it's not like, well, I can't do the hips because that child can't use crutches. What I am lucky is that I have very good physical therapists. So if I do a number of operations on the lower extremities, and people are wondering, well, how are you going to teach this child to walk? Our physical therapists will come up with ways of modifying a walker. So regardless of what the arms look like, they can still use that walker and support themselves with their arms as they're learning how to walk. But for the most part, the most significant thing that my upper extremity physicians can do with me is timing procedures. So very often what we'll try to do is if I'm going to the operating room to do something, I'll invite them in to do something as well. So that's less times that the child has to go to the operating room. And even we'll operate in tandem, that they're doing something at the upper extremity on the left side and I'm doing something at the lower extremity on the right side, so that the operative time is even short.
Okay, good. But another question regarding the upper limb, because many of the children will require the walking aids. So the tricep function would be spared. So would you consider about the tricep lengthening or triceplasty for the congenital extension contracture? They will have the extension contracture of elbow also. Should you preserve the tricep?
Yeah, so we're perfectly happy with that, because then I'll just have them use a walker that has forearm platforms or crutches that have forearm platforms. And they do quite well with those. The remarkable thing, especially with the children with amyoplasia, is how well they learn to adapt. Whatever you do, if they can figure out how to adapt around it. And so if you come up with things such as platform walkers, they do well with that.
Okay. Now, one question from my side. I noticed that you reduce the dislocation of the knee later. So would you not find any issue with the remodeling potential of the condyle, because the condyle would be dislocated, the knee is dislocated for a long time, and the growth potential of the knee is best in first year of life? Why you are delaying the surgery?
You're very right about that. And I will tell you, so for me, there are two unanswered questions in arthrogryposis, two things I'm struggling with. And I mentioned the hips a couple of times. Those are the hips that don't flex well. I'm still trying to figure out what to do with those. And I've actually now I've been at the Shriners Hospital here for 12 years. And so the patients I started treating early on when I got here are now all getting to an age where they're older, and what I've said, I'm going to put off addressing your lack of hip flexion until you're older. Now they're older. Now I have to do something about it. So to digress for a second, with those hips that don't flex up very well, what I've been doing lately is getting a CT scan of their pelvis to figure out what's going on with their hips. And very often what I'll find, I just happen to have this little model here, I don't know if you can see, is that their femoral heads are actually sitting somewhat anterior.
Yeah.
There we go. The femoral heads are sitting somewhat anterior in the acetabulum. And they also have this terrific external rotation of the proximal femur. Yeah. So what I've been doing for them is making a proximal femoral osteotomy, rotating the hip back into a normal version, and then doing an open reduction of the hip, doing a chondroplasty of the front of the femoral head. There we go. Okay. Doing chondroplasty of the femoral head. and then trying to do that to get them to flex up better. Now, in terms of the knees, that's also same thing. I used to say, I'm going to wait until you're 10 years of age, and then I'll worry about the knees. Because my feeling was, well, the kids with the knee extension contractures, they can learn to walk with their knees straight. And I'm worried that if I bend those knees, it's going to make it harder for them to relearn how to walk. But I'm now coming back from that. I'm now thinking, well, I've got a number of these children that they're 10 or 12. I get their knees to bend, but yeah, they look very incongruent, and maybe I should be doing something sooner. So I don't know. I'm in flux on that. And, if we have this conversation in 2 years or 5 years time, it might be a completely different conversation at that time. So we'll just have to see.
Thank you. But did you see the Charlie Johnston's paper on the femoral shortening and ipsilateral reducing the hip and knee at the same time?
No, I haven't seen that one. Oh, you're ahead of me on that. I'm going to have to look that one up.
Okay. That's it, because there are many people that's practice of the reducing hip and knee together.
Yeah, I know that down in Florida, Dave Feldman at the Paley Institute likes to do a very large exposure of the hip and knee at the same time. What I haven't seen from them is any kind of a follow-up, so I don't know how stiff things come, but I'm going to have to look up Charlie's paper. Now, what's interesting about that is when I presented my work on the hips, that it was actually Charlie who said, I don't understand why you're doing all this work because these children never walk. So it's nice to see that he's come back from that and actually trying to be more proactive about getting them up walking.
Okay. The last two questions, the traditional the teaching, because they are stiff on from beginning. So there is a role of the controversial role of capsulorrhaphy in case of the open reduction of hip. What are your views for doing anterior open reduction and capsulorrhaphy?
Right. So when you do the medial approach, you can't do a capsulorrhaphy.
Yeah.
But that's again why tethering that ligament to teres really works well. So when you do an anterior approach and you do the capsulorrhaphy, you feel very comfortable that your hip is in socket. But if you do the same thing with the ligamentum teres, then you're also very comfortable that the hip is staying in socket. To digress one step further, is that I've had a handful of times where whatever I did, I could get the ball to sit inside the socket, but it just seemed very unstable. And I was worried what would happen if I put on my cast. So I started doing what Pablo Castaneda talks about, actually putting a wire across the hip joint. So kind of going through the greater trochanter across the hip joint to hold that in place. And when you take off your spica cast, you pull that wire out. And that's worked out pretty well. The problem is that you get a pin site infection very often because they're still wiggling inside that cast and the skin and the muscle wiggle against the wire. And that can be kind of a messy thing when you take the pin out. But again, with the medial approach, not doing a capsulorrhaphy, but tethering the ligamentum teres has worked very well for me.
Good. And what are your indication of doing the acetabuloplasty? If you do the in young patient open reduction, when would you consider do the acetabuloplasty? Because there is a lot of controversy. Some people say do it early. Some people say in arthrogryposis, it doesn't require.
So for me, I've done them later. Again, I do know I have a colleague of mine in Japan who waits until the children are about 2.5 years of age, and then he will always do a Dega or a Salter. But for me, I've only on the older children that really look like they have a deficient acetabulum will I do those procedures, and then I'll do an anterior approach. But by and large, for most of the children that I treat under 2.5 years of age or so, I will just do a strict medial approach. In most of the cases, the acetabulum remodels, but there are definitely those that have to take back to the operating room years later on to do an acetabular procedure.
Okay, thanks. One more question pop up that Dr. Jen Sampath is asking. The cordyceps tenotomy is for infancy. What is your approach for severe congenital dislocation of the knee joint at birth?
So at birth, if they have a hyperextended knee, then I will start to cast that knee. I won't even try to cast the foot. I'll just try to cast the knee. And I've had very good luck with that. I haven't had any of the infants that I've been able to get to with that hyperextended knee, I haven't had to operate on any of those just to get the knee to a normal range, to get it so it doesn't hyperextend. But if I've gotten to them later on, if they're a couple years old when I first see them, then yeah, you have to do some sort of a quadriceps lengthening procedure just to get the knee to get down to at least regular extension.
Okay, the one more question. What about the anesthesia in a child younger than 6 months in arthrogryposis case?
That's a good question. So there are very, very few things that I will take a child to the operating room for under a year of age in arthrogryposis. So like I was saying in my presentation, the hips, I'll usually wait till they're at least a year old. And for the club feet, for example, I will do my percutaneous Achilles tenotomies in the clinic with just a local anesthesia. So I try to keep them out of the operating room. I try to keep them away from general anesthesia until they're at least a year old.
Okay. Thank you very much. But earliest age, when will you do the hip reduction, the open reduction of hip?
About a year.
About a year. Okay.
Yeah.
Thanks. So now we are going to show some of the cases. Okay. So.
And by the way, those were some really good questions. You really made me think there.
So, can you see the screen?
Yes,
Yep.
please.
Yes. So we'll have the 6-7 cases. Professor K. Sriram will present the first two cases, and Dr. Bobby John will take over another 2 cases. Then at last I will present a few cases. Yes, sir. Dr. Sriram.
Yeah, I'll just do it. It's easier for me to do it. Huh?
Yeah.
So the first case is a female child, one of twins, premature history of RDS at birth, born in 2016. First, the other twin was normal. This child had AMC, bilateral dislocated knees, bilateral DDH, and bilateral vertical tali at birth. So those were the X-rays: hips out, knees out, and the vertical tali, which are quite obvious. So what we did, so these are the questions which have been put up. What should be dealt first? Hips, knee, or feet? And what are the options for the treatment?
So the first thing for me is trying to figure out what is the cause of the arthrogryposis. This is a very fascinating case. We know that amyoplasia happens disproportionately frequently in sets of identical twins, oftentimes where they share the same placenta. So my first question is, are these identical twins? And my guess is they probably are not identical twins. Do you happen to know that?
No, we're not sure whether they were identical or not, because when they don't look the same. One child is normal, one child is AMC.
Right. Well, I mean, that's the interesting thing with the identical twins, is that one will be normal and one will have AMC, but they still look the same facially. But so here I was thinking that probably this child probably does not have amyoplasia for a few reasons. The most important is that congenital vertical talus rarely, if ever, happens in amyoplasia. So then you start thinking about other things. And the things that come to mind are the distal arthrogryposes and also Larsen syndrome. And Larsen syndrome can have the congenital vertical talus, the hyperextended knees, and the dislocated hips. So this to me looks like somebody that might have Larsen syndrome. So what does that mean? Where would I start with this? I would probably start with trying to stretch the knees out with casting. So I'd only concentrate on the knees at that point. I wouldn't worry about the feet. In Larsen syndrome, and maybe also with hyperextended knees that aren't related to Larsen syndrome, sometimes what you need to do is actually do an open procedure because the knees are so unstable. So you have to do an open procedure to get the knees more stable. So once you're able to lengthen the quadriceps, get the knee to flex, then you have to do cross K-wires across the knee joint itself to hold things in place as they kind of stiffen up postoperatively. But so I would probably do the knees first. And then it's kind of dealer's choice. In my hands, I would probably look to do the casting of the feet for the congenital vertical tali. And that's the technique that Matt Dobbs described, where you're trying to plantar flex the foot and actually supinate the foot over. And as you're doing that, the foot relaxes enough that really all you need to do then is do a small open reduction to the talar navicular joint. And if I was brave enough, I would do that at the same time that foot surgery as I did the hips. So knees first, get that all fixed up so the knees can flex. And then maybe a year later, do the stretching casts of the feet. And when the feet are ready for the procedure, go to the operating room and do both the hips and the feet at the same time. But that's, you know, looking at it now, I don't know if looking at the clinic, I might have a slightly different idea of what would work.
Okay, thank you.
So this is what is done, exactly what you said. We did serial casting followed by just a rectus stenotomy, and both knees got reduced. Retained the cast for 2 months, and then we gave these anterior knee splints. At 10 months of age, we did a reduction of the hips. You know, the right hip went in closed, did a medial open reduction of the left hip. And at 1.5 years of age, we did an open reduction of the vertical tali after a few casts. So that was the knees, which went in with just a simple, you know, tenotomy of the rectus. And then the hips, the right went in close, the left had a medial open reduction. And then follow up, the hips are done reasonably well, no problem. The knees are done well, and this is the child walking.
I think that's a fantastic outcome. Both because you have this child walking without any bracing at all. Those knees look like they move nicely. And what really impressed me was what those hips look like, particularly because it's rare to be able to do a closed reduction on an arthrogrypotic hip. And the fact that you're able to get the hip into joint and get the joint to remodel so well and have a great range of motion is very impressive. So I think it really worked out well.
Is this what we would call a distal arthrogryposis, where the involvement is not so systemic?
Vijay, the kids look similar in that video.
Yeah, they do, sort of.
Yeah, hard to say. The hands look, in this case, the hands that I see look very,
they look good.
Very good.
No evidence of Larson's.
I'm sorry?
There is
no evidence of
Larson's, no.
No.
Yeah, the exam is quite normal.
The Larson will have excessive, the extra ossification of carpal and tarsal bone and laxity. If there is no laxity, there is no Larson's involved.
Not there. The hyperlaxity is not there.
Yeah.
So my friend Judy Hall says there are 400 different things
Yes.
that can lead to a child having arthrogryposis. So it's way beyond the different conditions that go way beyond what I can enumerate.
Yeah. That's fine. So we'll go for case 2, Vijay.
Yeah, this was he was another boy with AMC, born with bilateral dislocated knees, then right hip dislocation, right CTV. He had deformities in both hands and wrists, and both elbows were stiff in extension. Yeah. So that is the clinical picture. And how do we deal with this now?
Again, same. What is the?
So with this child gets some flexion of the knees. And as I sit here today, I would say I'm going to hold off on addressing those. But like I said, that's probably going to change in the next few years as I have a better idea of what I want to do about the knees. So for me, it would be starting off with the feet, doing regular serial casting of the feet. And maybe I'll try for some more knee flexion in the Ponseti cast that I apply. And then at the end of the casting, we'll do a percutaneous Achilles tenotomy in the clinic. I don't use the standard Ponseti boots and bars for my arthrogryposis patients. That works very well for the idiopathic patients, but for the arthrogryposis patients, my experience is that they get a very quick relapse of their club foot. And I think it's because in the braces, they are not kicking as much as a typical child. A typical child does a lot of kicking, and I think that's what helps them stretch out. Whereas an arthrogryposis child just doesn't have the muscles to be able to do that. So I will use AFOs, and typically I'll have little dorsiflexion straps. So at nighttime, we put the dorsiflexion straps to try to stretch out the Achilles some. And then probably at about a year and a half, I then look to address the hip and hold off addressing the knees for a period of time. Particularly that left knee makes me pretty happy. That seems to flex almost 90 degrees. And I'd expect that that child will do very well without having to have much done at all for the knee.
This child had a lot of procedures. So at 1 month, we did an open reduction of the left knee, right adductor tenotomy. And then at 3 months, there was a congenital dislocation of the right patella, which was corrected with the quadriceps plasty. And then at 6 months, we just shortened the humerus on the left side to give a little flexion to the left elbow. And then at 1.5 years, we did a right hip open reduction, femoral shortening, and a varus osteotomy. At 2 years, 10 months, we repeated that varus osteotomy with an osteoplasty. Some work on the hands were done, rotational osteotomy of the tibia. A thumbed palm correction was done at 13 years and 8 months. And then at 14 years, which was delayed for a limb-leg discrepancy, we did a pan-inferior of the left knee. But that was delayed. We should have done that earlier to get better leg length. So that was these are the X-rays. So at 1.5 years, you can see the post-op X-ray. We took a CT, it shows that it's in. And then we did the varus and the osteoplasty.
4 years.
At 4 years, 8 months. That is the follow-up. And then what happened to him later on was that he went into an AVN. And it's a stiff hip. He's got a limb-leg discrepancy of 6 centimeters. So we put this up just to show that this open reduction of the hip in AMC is not always great. And that's him now at 14 years. And yeah, his feet remain corrected. We've got reasonable flexion of the knees. His hands didn't do too well after the surgeries. They still remain flexed and stiff. So he has problems holding on to a walker. And this is how he ambulates. So, yeah.
So you're kind of in a similar place in your career as I am, where you get to start watching these children as they're getting older, and either feeling very good about things or wondering what you could have done better. I think those knees look quite good, how they're moving. And yeah, from the X-ray of the hip, that certainly looks to be one of the more troublesome areas. But that might be the type of thing that if you have enough range of motion, that you could think about doing a pelvic support osteotomy, such as I showed with that one girl, to see if you can then improve the muscle function around the hip. So the pelvic support osteotomy isn't just to relieve discomfort around a congenitally dislocated hip, or I've even done it in children kind of like this with severe AVN or just a congenital lack of a femoral head. But it brings the greater trochanter distal and lateral, so it increases the function of the hip abductors. And that can help them walk better and can improve their Trendelenburg gait. So that might be one thing to think about with this child. Because I think otherwise, besides that hip, everything looks really good. Those feet look great.
Yeah. Thank you. We'll ask the Bobby John to present the third and fourth case.
Thanks, Hitesh.
Yeah. Let's start with the first one. You can say.
So my first case is a 3-year-old girl who's presented with a bilateral 40-degree flexion deformity of her knees, besides the deformities in her feet and hand. And the range of movement of the knees were 40 to 140 degrees bilaterally. So she's 3 years old with a 40-degree flexion deformity of the knees, with a range of movement of 40 to 140 bilaterally. Now she had an untreated flexion deformity of her knees with no subluxation or dislocation. I'm sorry, I don't have access to her previous x-rays to show you, but this is how she walked in. So this is her gait before surgery. She definitely has a problem straightening her knee and trying to stand and walk. So the question is, how do we treat this child?
You already gave us a little bit of a teaser there. It looks like whatever you did worked out quite well. But so for, in my practice, a 3-year-old with a 40-degree knee flexion contracture, I would look to treat with the hemiepiphysiodesis plates. And it'd be more a matter of trying to figure out, typically I would do a posterior knee release with a 40-degree contracture. But what is really nice to see is that if she flexes up to 40 degrees, it sounds like she already is a very flexible child. And occasionally I've been able to cheat a little bit and not do the posterior knee release, but just be very aggressive. So I would put the plates in. I would still put them in a cast postoperatively to get some extra stretch on them. And a month later, I would change them over to a KAFO that they would at least wear every night to stretch them out some.
Fair enough. So what we've done is a simple medial hamstring release and put her into a cast for 6 weeks. And this is what she looked like at the end of the surgery. And Hitesh, if you could go on to the next one, which shows the gait. And this is how she walked at 2 months. And this is her at 6 months. In our circumstances, you need to take into consideration that a lot of these patients may not be able to come back for frequent visits. There are parents who are working, and it may not be easy for them to come back for regular follow-up. So whatever you do should be a one-time procedure with minimal visits back to the clinic.
Yep.
I mean, it could very well be even sort of treated with serial stretching and casts. So that calls for repeated visits to the hospital before you try and do, a soft tissue correction. So here's an example of something that was done, very well knowing that, a part of the deformity might recur as she grows up. But
I think that, I think that you've done very well. And I've had the occasional child that was similar, that when you looked at them, you noticed that they had very tight hamstrings that really stood out when you try to get the knee straight. And so I can also think of a few patients where I've just done a percutaneous hamstring tenotomy. And I think usually, again, I'll put them in a cast for a little bit of time after that, that have also done very well. And I just wish I had more of those, but because they usually need more than that. And, the other thing that I certainly also realize is that I am lucky where I can get braces for almost all my patients, particularly not just here in the US, but working at the hospital I do, where, we don't care if somebody has insurance, we will always be able to give them braces. Because I'm sure that's probably a harder thing when in my time in India, I know that could sometimes be a very difficult thing, is being able to get somebody braces. And braces for me are such an important part of my practice for these children.
True. Any other comments on that?
No, I thought that was a very nice case.
Great.
Do you have any plans for the feet at this time?
Not as of now, because she's plantigrade, she's walking, so we've left her alone for them. What would you suggest?
I think it was the right foot that looked like it was very everted. So I'd like to understand that foot better. I'm sure if it had a congenital vertical talus, you would already have picked up on that. But that might be the kind of foot, again, in my practice, I would probably maybe do some stretching casts, put them in a brace for a while. And then when they're substantially older, when she's 10 to 12 years of age, maybe doing some extra articular osteotomy. So I like to do a sliding calcaneal osteotomy. And maybe something through the midfoot to get the foot leveled out. Or if it's a more mild case, then I would just do something that's a more standard Mosca procedure, what Vince Mosca does with the lengthening of the calcaneal neck and a plantar flexion osteotomy, the medial cuneiform.
Sure. The priority here right now was to get her standing and walking.
Yeah, and she's done that very nicely.
Down the line, I'm sure, the foot can be taken care of. Fair enough. So this is the second case. Now, this is a 7-year-old with a bilateral untreated dislocation of the hips. So she presents at 7 years. She had a bilateral deformity of her knees. The left knee was subluxed with a flexion deformity of about 45 degrees and a valgus of 60 degrees. So on the left side, there's a flexion of 45 and a valgus of 60 with a range of movement, an arc of movement of 45 to 60 degrees. So 45 degrees of flexion, 60 degrees of valgus, and an arc of movement of 45 to 60. And the next picture shows the images. And on the right side, there is a very minimal deformity, less than 20 degrees.
Goodness, you guys find some very challenging cases. And that is a very strange looking distal femur over there on the left.
Yeah.
Was there any history of a neonatal sepsis or anything that could have caused this?
No, nothing. Nothing that we are aware of.
Yeah, because it's interesting how oblique that physis is, and hard for me to figure out that's more in the coronal plane or more in the sagittal plane. But I would probably want to, my thought, just again, looking at this here without having a patient in front of me, oh boy.
This is what you look like, yeah.
Yeah, goodness. I might think of trying to correct that out with bony osteotomies, because it does seem to be more of a deformity within the distal femur itself before I tried to do more with the knee. Before seeing those x-rays, when you said that you had a flexion contracture with a valgus component, I was thinking more of some sort of a rotatory subluxation. Mm-hmm. And in those knees, I've treated them with an Alizaroff, where I'll do a posterior knee release, use the Alizaroff to correct the subluxation, and then slowly straighten out the knee. But this case, I think, is different from that. I think there's a deformity within the bone itself.
That's right. So this is what she looked like, and that was the, the gait, how she walked. So she was actually taken up for a deformity correction of the left knee with a supracondylar osteotomy, which is further stabilized with an Alizaroff fixator to correct the residual valgus deformity. So this is what she looked like at the end of correction. And the next image, Hitesh. Any comments on this?
That looks like a beautiful, even before seeing the x-rays, just the clinical result looked excellent.
So this is how she walks now. And she's barely 5 months post-op. So the first image was just after surgery when she got walking, and the second image is when she started to walk at 5 months. It's still a bit too early to comment on the final outcome, but definitely the hip needs to be taken care of, hopefully with a PSO, so that the trochanter can be distalized and improve on the abduction and the gait.
Yeah, that is a wonderful result. And of course, as young as she is, you're going to just need to watch that physis carefully, because
that's right.
Whatever caused it to become so deformed may keep on giving you trouble. But I think she looks really, really good here. And you're a man after my own heart using Alizaroff on a child with arthrogryposis. I think that's it's such a very useful tool for these children with the tough knees.
Thank you.
Thank you, Dr. Vijay. Now that 5 minutes are there, I will show some other case. Similar to Dr. Sriram's case, we had the child with the arthrogryposis with the bilateral hip dislocation and the vertical talus. So here the knee was okay. So we treated the vertical talus with the manipulation and casting, and we did the medial open reduction simultaneously. And that's 6 months, 2 years. That's 5 years.
Those are very
Child is
nice
walking
results.
without any orthosis, and hip is doing quite okay. Any
those are very
comment
good.
on that?
Yeah, I think those are very good looking hips. And I think your treatment is exactly the same as what I would choose to do too. And it's nice to see how they came out. So these, you said you did these through medial approaches?
Are you able to see?
Yep, can you hear me? Can you hear me at all?
No, Hitesh, there is a problem with your
Okay, I'll not
voice.
go in other one. So we had
can
the
eat.
similar.
Yes, Sandeep, can you take over now?
Yes.
Okay. Okay. So, Dr. Harold Van Bos, thank you very much. That was really a magical journey through one of the most difficult problems that pediatric
Yes,
orthopedic
but
surgeons have to
This
face.
is little.
Hello.
Yep, I'm still here.
Yeah. So thank you very much for that magical journey through the world of arthrogrypotic kids. I think it is one of the most challenging kind of conditions that all of us have to tackle with. And especially with the insights that you have given us of medial approach and tethering of the ligamentum teres, probably people can tackle the hips better. And it was lovely to see the morphological correction that you aimed for and the beautiful remodeling that happens as the child grows. And the end result made it all worthwhile, all that effort which you made, which ultimately resulted in the child walking. So that gives us a message that it's worthwhile trying to straighten out the legs and stabilizing them as much as possible. The power may or may not be there, but they do adapt and manage very well. So thank you for those wonderful messages. And I would thank Professor Sriram, Vijay, Dr. Bobby John, and Hitesh for such wonderful Indian cases, so that you get a perspective of the neglect that we have to deal with. Not only arthrogryposis, but they come late, they behave a little differently, and we have to do with limited resources and tools. And probably we don't have the custom fit orthosis that you have access to. But it's been absolutely amazing and wonderful, and we would like to hear more from you in the future. So with those words, thank you very much again.
Well, thank you very much. It would be my pleasure to continue this conversation another time. A couple of things I would like to say is that, first of all, I really appreciate the audience. I think the questions that were asked were excellent. They made me think a lot, and I'll keep on thinking about those for the next few weeks, I'm sure. The cases were really outstanding cases, and it's neat to see that we're so far apart in this world geographically, but I think that philosophically we're very similar in terms of how we treat these children. You have some wonderful results that you got there, and I think that you probably in India have patients with a little bit more vim and vigor than we have here, because seeing that how you got those children up walking at such an early age after surgery was really eye-opening. So I'm very proud of what you've done over there.
Thank you. Thank you very much. So good night, folks. Stay safe, wear your mask, and keep distance.
Thanks.
Thank
Okay,
you.
yeah.
Bye-bye
Thank
now.
you.
Thanks.
Bye-bye. Bye-bye.
Thanks for
Harold.
inviting me.
Yeah.